Thanks, Rachel, and of course thank you to everybody for coming in today. I know that everybody has a lot of other activities and things that we could all be doing, chiefly surrounding the idea of staying warm, but I'm happy that you all came out tonight, and what I'm going to do today is present to you what I think were some of the highlights of this meeting. Now, there's a reason that our community outreach program includes this San Antonio review essentially every year. And that is because this is probably the most important meeting for those of us who are clinically interested in treating breast cancer and for basic scientists who are looking into the basic biology and therapeutic targets for breast cancer. So there's a lot that goes on, there's a lot of important information, and there's no way that in a short period of time we can cover all of it. But I'm going to try to cover the things that I think are clinically most important, hopefully that we can get some take-home messages on. I'm going to finish up by talking about something that was presented last year and give you an update on it from this year. That's always good. And then after that, we'll do some questions and answers. Everybody just be aware that in the question and answer period, I'm more than happy to address your questions. Please don't ask personal questions or ask questions about someone's specific cancer-related care. I can't answer those questions in an appropriate and accurate way, so let's keep the questions a little bit more general, and then maybe we can spend some time and talk about the topics that you're very interested in. So the San Antonio Breast Cancer Conference, what's the best way to advance the slides, Rachel? Is there a better way to do this? Okay, can we just use the arrows? Yeah. Okay. So the San Antonio Breast Cancer meeting includes presentations in a variety of different manners. And one of the most important types of presentations are the plenary lectures. These are lectures that are invited, so an identified expert in the field is invited to come and give a talk, and this is a talk that takes place when nothing else is going on, so that the majority of attendees at the meeting will be able to be present at this talk and not distracted by other kinds of information. So the first plenary talk this year at San Antonio was given by Dr. Catherine Briskin from the United Kingdom, who is a basic science researcher, and she did a really wonderfully organized and interesting talk about hormones and the breast. She titled it Hormones and the Breast, Local and Environmental Interactions, and she based this talk on many years of research that she had conducted in her laboratory to try to clarify some of the relationships between these female hormones that are in our body and breast cancer. She presented a lot of experimental information, and I'm going to capsulize it for you in terms of the more clinical takeaway messages. So based on lots and lots of really good detailed information in mouse models, it seems very clear that estrogen is the primary driver of pubertal development of the breast. So at the time of puberty, when women's breasts go through this big, enormous change from being kind of quiescent to being very functional, estrogen is the hormone that drives the cellular proliferation and the changes within the breast tissue. But after that point, after puberty, the other main female hormone, progesterone, drives cell proliferation more than estrogen. And this is an interesting observation that tells us a little bit more about the relationship between these two, and that maybe has an impact when we think later on about breast cancer. Now, I'm also going to show you some slides that she presented at the very end of her talk, talking about environmental exposure to bisphenol A, which is something that we find a lot in our environment in the modern world, and that the response of breast tissue in the adult, the response of breast tissue to progesterone in terms of proliferation in the adult, is actually increased when breast tissue is exposed to this chemical BPA. Now, this is a little bit of a cartoon diagram, and it shows a few things. In the normal breast, only a very few cells are actually estrogen and progesterone receptor positive. Now, there are a lot of you in this audience who know a lot about breast cancer, and you know that when we talk about breast cancer cells, we talk about whether or not they are estrogen progesterone receptor positive, ERPR positive, meaning do the cells proliferate if exposed to the hormones? Well, it turns out that that's not just a characteristic of breast cancer cells, it's also characteristic of normal breast cells. And a small percentage of the cells in the normal breast do proliferate in response to estrogen and progesterone. And that's depicted here by this kind of a cell. Now, when progesterone comes into the picture, here in the yellow, estrogen can only make this cell grow by direct action. Progesterone can also make this cell grow by direct action, but progesterone is also capable of making these non-ERPR positive cells proliferate by an indirect action through other intermediary compounds. This shows you a cartoon of what goes on in the menstrual cycle. We can see that during the menstrual cycle, a normal woman's body elaborates both estrogen and progesterone, and that estrogen can cause, as we said, a small proportion of the cells to proliferate. Progesterone increases the cells that can proliferate, and then there are other intermediaries, which are all these very complicated names over here, that can act both on hormone receptor positive and negative cells to cause proliferation. It seems like the indirect action of progesterone on this special compounds called rank ligands actually activates some of the stem cells in the breast to proliferate, causing tissue remodeling and growth and proliferation. The more that goes on, as you can see on the y-axis, the greater the breast cancer risk. So this clarified for us some of the basic science around how these normal female hormones cause breast tissue to grow and proliferate. Now, what was fascinating about this talk, because I'm sure everybody's yawning right now, that's a basic science concept. I find it interesting. Maybe you don't find it so interesting. A lot of mice died to prove that. But what she found, and this was really, really critical here, is that exposure to this chemical, BPA, you've heard a lot about this in the last few years, right? They banned it from the baby bottles and so forth. You get exposed to it from the credit card receipts that print out from those little, machines in the restaurants. When BPA is in the system and we're exposed to a lot of BPA, it takes all of this sort of typical normal proliferation and ratchets it up, okay? It bumps it up more. In the presence of BPA, all of this proliferation that's induced by the hormones is actually ratcheted up a notch, which leads to the theory, which is not proven, that perhaps environmental exposure to BPA may be something that increases the risk of breast cancer. This is a hypothesis generated from this very interesting data, and certainly something that needs to be looked into further, but I think it's a concern of all of us as we think about and consider environmental exposures and the potential relationship to breast cancer risk. So this was a terrific lecture to be part of. I'm glad I got a chance to hear this data. One of the most talked about papers that was presented at the San Antonio conference is something that most of you probably heard about in the lay press. This was covered by the Times, it was covered by a lot of media outlets, and it was the Atlas trial, which was a trial that this portion of the trial looked at the duration of treatment of tamoxifen and whether or not extending treatment from 5 years to 10 would provide additional benefit to patients. And this was highly anticipated and talked about a great deal. So just to review how the study was conducted, this was a collaborative worldwide trial which involved almost 7,000 women who had hormone receptor positive, estrogen receptor positive breast cancer. And in this part of the trial, they looked at women who had already received 5 years of treatment with tamoxifen, which is a medication that's been used for many years as part of the hormonal treatment for breast cancer. Women who had 5 years of tamoxifen were then randomized to either stop right there, stop the treatment, or to continue for an additional 5 years of treatment. And this study was conducted with patients that were enrolled from 1996 till 2005. So the mean follow-up at this point is about 7.1 years. That's good. We feel like the results are more mature when we follow the patients longer. And one of the things that they demonstrated in this part of the trial was that compliance was about 80%. Compliance means how many patients actually went through with it. They took the drug every day the way they were directed for the duration of the study. 80%, maybe it doesn't look so good because obviously maybe our data is flawed because people didn't really take the drug the way they were supposed to. But tamoxifen is notoriously difficult for some people who get a lot of side effects. So truth be told, 80% compliance is pretty much average in most trials of tamoxifen. Now, this is just a slide from the actual presentation from the Atlas group. So it was 10 years of tamoxifen versus 5, and this is the way the study was laid out. Now, when you look at that, there's something missing. If we really want to think about the benefit of tamoxifen, then shouldn't we have a control group where women didn't take the drug at all? A placebo arm, if you will. And the answer is that in this day and age, it was considered inappropriate, potentially not ethical, to have women randomized to not receive the drug. So there was no placebo arm. But in order for the study investigators to still understand the real benefit of tamoxifen, what they did, which was very elegant, was to look back at older data to create a placebo arm. Now, in the Atlas trial, about 54% of patients were node negative, and this is some of the results. So what they saw at the end of the study period was that in the group of women who took tamoxifen for 10 years versus 5, they had fewer recurrences. Total of 617 versus 711. They seemed to have less mortality from breast cancer, and the overall mortality from all causes was also decreased. But what they also found was both recurrence and mortality were little affected during years 5 to 9, and that the benefit mostly was seen after that time period, after year 10, actually when the drug treatment was discontinued. Okay, so as we said before, how do we make sense of these numbers, and how do we understand how much benefit the patients really got? Well, first of all, they went back to this older meta-analysis, which was a composite of many, many, many trials looking at tamoxifen treatment to look at women who took it for 5 years versus women who didn't take it at all for hormone-sensitive breast cancer. And what they found, and this is something that we've known, is that taking tamoxifen reduced the mortality from breast cancer during the period of time when people were taking the drug, during the time period after they stopped taking the drug, and even years in the future. So taking tamoxifen for 5 years affords benefit to patients during the time they take it, and then there's a big tail of benefit that they get even after they stop the drug. Okay, that may be news to you guys. That's not news to us. Very important. The benefit doesn't stop when you stop taking the drug. So then how are we going to take this information about the tail of the benefit and figure out how much more benefit you get if you just keep taking the drug during that time? Okay, so the researchers then said, let's look at our data for the women who took 10 years versus 5. And let's consider the 10-year group as the index for comparison. So what they found is that in years 5 to 9 really didn't see a big difference between women who were taking the drug or women who had completed it. But it was after the time period, after the 10 years, that they continued to see a benefit. Now, this 0.73 hazard ratio, which means a reduction of 27% in breast cancer risk seen after only 5 years of tamoxifen, is then compared with a 0.71 or 29% decrease in breast cancer death rate from the 10 years. So they definitely saw an improvement, albeit small, and this was statistically significant. And I'm going to show you that data in some graphic form in a minute, which may be a little bit clearer. Now remember that tamoxifen's a drug. Every drug has side effects. And they needed to be serious to look at what the consequences would be of exposing women to this drug for additional years. So again, comparing to the 5-year data, 5 years of tamoxifen versus nothing, what they found is that the risk of cancer of the uterus and of thromboembolic phenomena, blood clots, pulmonary emboli, was about the same, 0.2%. But that the breast cancer gains were higher than the side effects seem to be. Now, this is the data that they presented. I'm not sure you can make these equivalent. I'm not sure that somebody who gets uterine cancer thinks that's a good trade-off. But this was designed to show that although there were definitely side effects seen from the tamoxifen, that in the opinion of the researchers, the gains in breast cancer mortality outweighed that increase in side effects by a great degree. Now, this is something that I think really shows this data in the most clear format. So what you see here on your left is the data comparing women who never took tamoxifen for their hormone-sensitive breast cancer versus women who took it for 5 years. So that's the foundation of the use of tamoxifen. And you can clearly see that, especially as you follow women out, that there's a big divergence in these two curves, and that women who took the tamoxifen had a lower mortality from breast cancer than women who never took the drug. Okay, the curves split. The absolute difference, 32.7% mortality in the control versus 23.6% in the tamoxifen group. So that's roughly a 10% divergence, but in a graphical sense, you can really see that 5 years of tamoxifen was highly beneficial in comparison with no tamoxifen. Now here, what we're looking at in the current ATLAS trial is the group of patients who took the tamoxifen for 5 years versus the group that took it for 10 years. And as you would expect, the observations were identical in the first few years of the trial because the patients were kind of doing the same things. They do begin to diverge, and the curves begin to diverge after the 10-year mark, and you can see that by 15 years, there is an almost 3% difference in breast cancer mortality in these two groups. Now, granted, 3% is not a big number, but this was a lot of women studied. This is statistically a significant benefit. And based on this information, the authors concluded that for women with hormone-sensitive breast cancer, 10 years of tamoxifen gives you an additional 3% absolute benefit versus 5 years of the drug. Now, a couple of cautions on the data. Number one, I would have liked to see some subsets. They just published this, so we'll see the full paper and take a good look at it. I'd like to see some subset analysis because I really want to know if somebody with a very early stage breast cancer is going to benefit as much as someone who's got more advanced disease. I think the answer is probably not. They're not the same. So we need a little bit of caution around that data. The second caution on the data is that, again, many of you are very sophisticated and know a lot about breast cancer, and so you know that today, for postmenopausal women, we don't really use tamoxifen as our first-line drug. We use drugs called aromatase inhibitors, and it is not clear that this data can be generalized to aromatase inhibitors, right? You follow? So it's not clear from this that 10 years of an aromatase inhibitor is better than 5 years with the same marginal difference, okay? So that's another caution. Can't generalize too much. How this affects women who transitioned during the study period from premenopausal to postmenopausal, also a little bit unclear. But I think what this suggests is that hormonal treatment for breast cancer, we may be looking at extending that treatment over time, and that unfortunately we know some women have these very late relapses that are unexpected and unanticipated. It's possible that those women would be benefited by extending their treatment. So stay tuned for more information, but this was a very big and important trial to study. The next presentation that I'd like to review with everybody is a meta-analysis of results from the collaborative trials in neoadjuvant breast cancer. So, by way of background, A meta-analysis means that researchers take a lot of trials that were all done separately by different people, but looked at the same basic study population and looked to answer the same kind of questions, and they try to take all the data and compile it together to see if they can show some significant results that are confirmed. Neoadjuvant treatment for breast cancer is the use of chemotherapy as the first treatment in sequence before surgery is done. And this is the approach we use today to women who present with extensive or advanced breast cancer. So this collaborative group wanted to look at lots of data from lots of different studies done all around the world, looking at how effective these treatments are and what subpopulations of patients maybe benefit more from this approach of chemotherapy before surgery. Now, getting down to this data, we've known for a very long time that a small fraction of women who use chemotherapy as their first line of treatment before surgery experience a pathological complete response, meaning that when they go to surgery, you can show that there is no more breast cancer that can be identified within the breast tissue and the lymph nodes underneath the arm. It's not common. It's a minority of patients. In the best trials, maybe 30, 40%. But it's been clear for a long time that women that have that experience do better than women whose cancer does not melt away from this treatment. But this study was undertaken to better understand the multiple aspects of this treatment, including the effect of breast cancer subtypes on the likelihood of someone having this pathological complete response. So, this is some information that just shows you what I just said, meaning that there's better event-free survival and overall survival in women who get this pathological complete response versus women who do not. And this has been corroborated by multiple trials. However, and I think for me, honestly, this was the most important slide that I saw in this talk. For me, I think what's very important is to look at the different subtypes of breast cancer to see which group of women had the best chance of getting that PCR. And if you look here at these patients who had HER2 positive breast cancers, biologically very aggressive kind of cancers, these women, especially the ones who also took the special targeted drug Herceptin, had a much better chance of getting a PCR, interestingly, as compared with women who had the kinds of breast cancers that we know to be less biologically aggressive, the ones that are actually hormone sensitive. And the triple negatives, right, not hormone sensitive, not Herceptin sensitive, today what we consider the most difficult kind of breast cancer to treat, these women actually had a better response to chemotherapy, more of a chance of getting that pathological complete response than the women with the biologically less aggressive cancers. So very, very interesting. It's good news for women, especially with triple negative breast cancers, that about 34% would get that PCR with the upfront chemotherapy, and that probably marks that group as having a better prognosis. It also means, and this is what I tell my patients, that if you have the less aggressive kind of breast cancer and you take that chemotherapy before surgery, if you don't see that the cancer has all melted away, that's not necessarily a discouraging thing. These cancers are much less likely to have those very vigorous responses to the neoadjuvant therapy. So what they concluded from their data is that women who have this pathological complete response have better long-term outcomes. We kind of knew that. This pathological complete response implies a better prognosis, and even if in the breast there's a little bit of intraductal carcinoma, the very early beginning of breast cancer, that doesn't change things. As long as there's no residual invasive cancer in the breast or in the lymph nodes, these patients have a better prognosis. And interestingly enough, that the PCR, the pathological complete response, is most associated with event-free survival, with going on to live without additional episodes of breast cancer in the breast cancer subtypes with the most aggressive biology, the HER2 positive and the triple negatives. Okay, so it really gave us a way, I think we're trying to hone down better, even with this neoadjuvant approach, about who's going to benefit most and who will not benefit so much from this approach. So very important data. Now, we talked a minute ago about patients who have breast cancers that are HER2 positive. These are cancers that are known to have a more aggressive biology, but the good news for these patients is the existence of the special drug called Herceptin, which is a kind of therapy that is targeted to only this kind of breast cancer. This kind of breast cancer represents about 25 to 30% of the total population. Now, since the drug has been in use, Herceptin, it has been standard for women to be treated for 1 year. This big trial called HERA, you always have to have a good acronym. You can't do a drug trial without a good acronym. The HERA trial was a big trial with lots and lots of different study populations, but what they presented here at San Antonio was the population of women who were randomized to either receive the Herceptin for 1 year or to extend treatment for 2 years. So we're echoing the Atlas trial, right? Is more better? And doctors sometimes think more is always better. Guess what? More is not always better, okay? So here in the HERA trial, this was a multi-institutional international trial, 5,000 women with HER2-enriched breast cancer, and we looked at women who were randomized to either 2 years of Herceptin or trastuzumab versus 1 year, and the study population was basically evenly split. And this is what it showed. No difference. Absolutely no difference in disease-free survival between the group that took the drug for 2 years and the group that took the drug for 1 year. The curves are essentially superimposed. Overall survival, once again, identical curves. So I think this was important, you know. You could say, well, it's a negative trial. Why are you highlighting this? It's important because, like I said, more is not always better. And we should challenge that assumption. And if additional treatment with the drug will not improve outcomes, then we certainly don't want to be exposing patients to any drug because every drug has potential side effects. And I'm particularly going to show that to you because while trastuzumab or Herceptin is generally extremely well tolerated by women, there are some clear side effects that can be seen with these drugs. And why would we expose women to the drug for longer periods of time if we're not going to gain additional benefit in disease-free or overall survival? Okay, so very important information. I'm just going to also draw your attention to the fact that this trial was conducted by BIG, which is the Breast International Group, led by Dr. Martine Picard, very important and prestigious international group trying to combine efforts at breast cancer research. So in summary, there was no evidence of long-term benefit for 2 years of Herceptin versus 1 year administered as sequential treatment after chemotherapy. And of course, some of the secondary endpoints and adverse events were increased in the arm where the patients took the drug for 2 years. These endpoints of these cardiac side effects were generally reversible, but again, we take that seriously. And if there's no additional benefit, why should we continue the treatment? Now, riffing on the idea of side effects, this was a very important report. And this report from the National Comprehensive Cancer Network looked at the occurrence of myelodysplastic syndrome and acute myelogenous leukemia after a breast cancer diagnosis. Now, these are really serious and often life-threatening diseases that have long been known to sometimes occur, rarely, in conjunction with chemotherapy. And there are particular drugs that are more associated with this than others. And I know that a lot of us have kind of had this in the news lately with the Robin Roberts story, right? You'll know about Robin Roberts from ABC News, who just had a transplant for MDS. So this is a very rare occurrence, but serious. And these investigators said, let's take a look at the biggest database that we can put together, and let's try to find out how often it happens and whether or not we can tease out a particular population of people who are more likely to experience this unfortunate occurrence versus others. So what they did is they said historically some of the other big trial groups have shown about a 0.3% risk of this myelodysplastic syndrome or acute myelogenous leukemia after adriamycin and Cytoxan at 8 years of follow-up. And they found that people who took chemo and radiation had a little bit of an increase in risk. A specific trial from the NSABP showed about a 0.5% risk of this complication at 5.3 years of follow-up. So the researchers in the current trial looked at the database from the National Comprehensive Cancer Network sites, from 8 sites, and it included women who were diagnosed with stage 1 to 3 breast cancer between 1997 and 2008, who were included in the database. Total patient load, 21,000 patients who were enrolled in this database from the NCCN sites. And overall, what they were able to glean is that the risk of the myelodysplastic syndrome, where the bone marrow stops making cells the way that it's supposed to, white cells and red cells, and or acute leukemia, was about 0.2% at a follow-up of 4.7 years. And the median time from the breast cancer diagnosis to this hematological disorder was 2.8 years. So low risk, but very important side effect to look at. So that was their overall statistic. Now remember, their statistics may be a little bit skewed because they were relying on institutions to accurately report when people had these conditions occur afterwards. So you might want to go back and take a better look at that. But they also tried then to break down the population to try to see, could they identify any particular characteristics that made someone more likely to get this severe occurrence. And they thought maybe women who were a little bit older, 60 years median versus 53.9 years, maybe that seems statistically significant as a characteristic that increased the risk of these hematological disorders. But race didn't seem to make any difference whatsoever. They looked at the characteristics of the breast cancer that prompted the treatment. They saw a little bit more of the leukemias, 51% occurred in patients who began at stage 1. That wasn't significant statistically. Didn't make a difference what the histology of the cancer was, no difference. And frankly, it didn't make a difference of any of the major characteristics about breast cancer that we look at. So whether or not somebody was going to go on to get leukemia had very little to do with the original breast cancer at the time of the diagnosis. Did it have anything to do with the way they were treated, with whether they had breast conserving surgery or mastectomy, or whether or not they had radiation treatment? And again, you see some numbers here that seem to be a little bit different, but statistically really could not identify a difference. Now remember, they only had 51 patients who went on to get leukemia. That's not a big population to study. Maybe when they update us in a few years, they'll be able to give us more information. But at this point, they couldn't really unravel anything that made a woman more likely to get this leukemia after breast cancer treatment. And again, there seem to be some differences in some characteristics regarding radiation treatment and in combination with chemotherapy and so on, but statistically, really not able to make any strong argument. So then they said, can we now create a situation where we can get a sense of what is the absolute risk of developing leukemia after breast cancer treatment based on the initial treatment? And what they were able to find is that women who had chemotherapy versus women who did not certainly saw a difference. So the link between the breast cancer treatment and these post-treatment leukemias is all about the chemo. It's the chemo that seems to be the underlying factor that creates the environment for the leukemias, and the other aspects of treatment do not. Again, very low risk. They looked at, they modeled this out at 10 years. The risk of developing these leukemias, well under 1%. The highest risk was 0.5% in the chemo subgroup at 10 years, so a very rare occurrence indeed. And their conclusions were that taking chemotherapy as part of breast cancer treatment was associated with a 10-year risk of leukemia of about 0.5%. That 0.5% is a little higher than some previous reports, but this is a big database and this may be a little bit more accurate. Most of the time this does not happen right away, but it happens after a number of years have passed. Radiation alone is certainly associated with these leukemias, but probably doesn't change anything in terms of patients who already had the chemotherapy. Chemotherapy is the big link, the big causative factor. They saw some other kinds of hematological disorders as well, and they felt that they needed to continue to monitor the database carefully in the coming years to learn more about the occurrence of these leukemias after breast cancer treatment. So again, we've heard about this with our example in the news of Robin Roberts. It is a very severe complication, however, extremely rare. Okay, so talking about breast cancer treatment and some complications, something that comes up all the time because it's a really big concern of women is chemo brain. The sense of being in a fog, the sense that during treatment and even afterwards, the cognitive functions are reduced, that people are not as sharp as they were, maybe their memory is not as good, and this is a very distressing experience for a lot of women with breast cancer. So these investigators did a prospective study and they wanted to look at certain neurocognitive changes, basically working memory, and they wanted to do it in a very scientific way by studying women after their breast cancer diagnosis before chemo even began and then afterwards, and also to get a sense of whether or not fatigue was related to this experience of chemo brain. As background, they said that what we all know is that there are lots of studies that have been done that have really shown some behavioral and cognitive deficits in women who take chemotherapy for breast cancer. Some of those studies, and the one that I know best was Felice Tager's study that was published in 2010, some of these studies showed that women did have some deficits even before they started the chemotherapy, and other studies helped identify the fact that where people tend to really suffer with the chemo brain experience is with ability to be attentive, working memory, processing speed, and executive functioning. So these are the categories that we use to classify our cognitive abilities. So I think this is the big slide of this presentation. This is a slide looking at working memory, okay, which is a pretty high function. And they looked at women at baseline, meaning before chemo and after chemo. They looked at women who were getting chemo. They looked at women who were receiving radiation. And then they matched them to a healthy group of controls to try to really understand the difference in the populations. So, not surprisingly, the healthy people really didn't change much during the study time. Okay, nothing was going on with them, no major illnesses, really no change. What they found is that women who were getting radiation started out with error rates that were pretty high in their memory, but that after treatment, this decreased, and they started to look a lot more like the healthy controls, radiation alone. What they found in the group that were getting chemotherapy, two very interesting things. First of all, even before they started treatment, they were having problems with the working memory. Significant problems. They're way above the healthy controls. They start out at about the same level as the people getting radiation, but then they actually go up. So after the chemo, there is a change, but not from baseline. They start out already having some impairment, and it gets worse when they're studied again after the treatment. Fatigue is a little bit of a mirror here, the experience of fatigue. Healthy controls, I don't know why they got more tired from the first measurement to the second. I don't know why. People getting radiation, their fatigue went up a little bit. We know that that can be associated with radiation. Chemotherapy, again, they start out higher than everybody else, and they get worse over time. So what the researchers concluded, and I only presented to you now a fraction of the data from this trial, but these are their conclusions. They felt that alterations or changes in working memory, neurocognitive processes, and also greater levels of fatigue were seen in women even before they received any adjuvant treatment, either chemotherapy or radiation. So just the diagnosis itself and going through that early phase of thinking about it and processing it already created a situation where people had impairment in working memory and they were already experiencing some fatigue. How much they were altered before they started treatment predicted the severity of what they would see after treatment. And there was a real correlation in all of the groups that they looked at between fatigue and the cognitive functions. So fatigue is a piece of it. People who are experiencing more fatigue also experienced more of a disruption in their thinking and memory. This is from the authors themselves. What are the key takeaways? Number one, chemo brain, probably not a good label. Probably doesn't describe the problem very well because a lot of it happens before the chemo even gets started. Before treatment starts, fatigue and what they're calling pre-treatment neural vulnerability, I don't know what that means. I don't know what that means. I think what it means is that people who have had a breast cancer diagnosis and have already gone through the diagnostic workup and surgery and so on are already distressed by those occurrences. That and fatigue contribute to these cognitive alterations, and that perhaps earlier interventions to reduce psychological distress might result in an improvement of these cognitive functions over the course of treatment. So chemo brain is not just about chemo. It's about a lot of other stuff. And if we address all the other stuff, we may improve people's experience and reduce their experience of chemo brain. Okay? Very, very interesting. So now I'm going to sort of switch from talking about women who have had breast cancer and gone through treatments and so on to a little bit of information that I think I find very interesting as a surgeon presenting to you today. And this study that I'm going to talk about right now is about high-risk women. And all of you who know me know that I have a big interest in women who are at high risk for breast cancer, and I think about this a lot. It's a big research interest of mine. And we've known for a very long time that there are conditions in the breast that you can discover when tissue is sampled in a biopsy, these conditions that are related to an increased risk for breast cancer, and they're called atypias or atypical hyperplasias. We've known also for many years that if someone has a needle biopsy, either under mammographic guidance, we call that a stereotactic biopsy, or under ultrasound guidance, if we see these atypias in the tissue, we've always recommended to women that they have a surgical biopsy, because sometimes that needle biopsy doesn't catch the most severe aspect of what's going on in the tissue, and there's always been about a 20% chance that if you do a surgical biopsy and remove that tissue, you'll find something more severe. Now people challenge that. They say, wait a minute now, these needle biopsies are getting better and better. We're getting better tissue samples. Do we really still need to take all these patients to surgery? And the answer is yes. And this data supports it. So historically, as we said, patients with these atypical hyperplasias and LCIS have always been recommended to have a surgical excision of the area after a needle biopsy, because 20% of the time you find something more severe, which can be the beginning of actual malignancy. And this study that was done out of Loyola in Chicago was undertaken to look at this in a contemporary setting of patients who had flat epithelial atypia identified on needle biopsy. And they looked at 726 needle biopsies done in a couple of years. 14 of them showed this atypical result. And then what happened when the patients went on to surgical biopsies? These biopsies were done with big needles, good representative samples, modern approach. The pathology from the surgical biopsy showed actual malignancy in, once again, 21% of the patients. And the authors felt that the study confirms the fact that even in a contemporary time period where our sampling methods are better and our pathology is more sophisticated, if we find these atypias on needle biopsy, the patient should still be recommended to have a surgical excision of the area to rule out something more severe going on. Next, in our thinking about higher risk women, was this thoughtful project done in Australia looking at the relationship of physical activity and the risk of breast cancer. So this is also very near and dear to our heart. Some of you, I hope, already know that here at NYU, we received some funding from the Charles Evans Foundation and actually in September launched a project offering a nutritional and exercise intervention to women with newly diagnosed breast cancer who were overweight. Because of this sense that there are many studies now in the medical literature that show us that exercise, diet, and weight management may have a beneficial effect on breast cancer outcome. So this is once again a meta-analysis. Let's take a lot of different studies, look at all of them in detail, put them together and see what we see. We remember that meta-analyses are always a little bit limited because each of the individual studies have different methodologies, look at different study populations, etc. But overall, what they found is exercise and weight loss were associated with a significant reduction in the risk of breast cancer, a 23% reduction for exercise and a 26% reduction with weight loss programs. So very important confirmation of that assessment. Now, it seemed like the benefit was a little bit greater in reducing the risk of cancer of the breast that happens in postmenopausal women. Also interesting, the intensity of exercise didn't seem to matter. Some of these studies looked at really high-level, intense exercise, 5 days a week, at least an hour a day, versus more moderate levels of exercise. I always love it when they tell me that 1 hour per day, 5 days a week is moderate. Oh my God, that's so not moderate. Wow, if you work, boy, you cannot do that. But they noticed that it wasn't the intensity of the exercise that seemed to make a difference. It was doing physical exercise per se, encouraging to a lot of us in terms of different ways that we get our physical activity. They also, when they looked at all these studies, you know, they were all done a little bit differently. And some of them looked at people's exercise habits when they were in adolescence or young adulthood or maturity, and they found that regardless of when this exercise was undertaken, when it was done on a regular basis, it still translated into a reduction in the risk of breast cancer. So I think from an overall perspective, really reinforces our concentration and attention to lifestyle factors and breast cancer prevention today. In overweight individuals, again, 20% risk, so made a difference, not a bigger difference than average weight individuals, but interestingly enough, didn't seem to make a difference as much in women. They tried to subset out women with different risk factors for breast cancer, and when they looked at women who had family history of breast cancer, they were not able to identify an exercise or weight loss benefit at all. So it may be that certain people, particularly those with genetic alterations and predispositions to breast cancer, their risk is fixed, and exercise and weight loss do not make as much of a difference as we would like. Now again, thinking about prevention of breast cancer, I'm going to present to you some data from our institution, from NYU, where we look at the use of drugs that are known to reduce the risk for breast cancer in women who were newly diagnosed in our institution. And there are actually 3 drugs that can be used to reduce the risk for breast cancer. Tamoxifen, which is the only drug available to premenopausal women, raloxifene or Evista, and exemestane or aromasin, both of which are used in postmenopausal women. And these drugs, all of them, have been shown to lower the risk of getting breast cancer when high-risk women take them for 5 years. And these agents, all 3 of them, have demonstrated at least a 50% reduction in breast cancer risk with a 5-year course of treatment. Now, these medications have been used for high-risk women, but we also know, I know a lot of you, again, know a lot about breast cancer. You know that these drugs, all 3 of them, have also sometimes been used in women who actually have breast cancer, particularly the tamoxifen and the exemestane. So what we wanted to do is to take a look at our newly diagnosed breast cancer patients and see how many of them had used these medications in the past, why they had used the medications, and then what kinds of breast cancers did they develop after these medications, or despite them. So we looked at our breast cancer database in a 2-year period of time, and in this period of time we had 996 patients enrolled, And of these patients who were newly diagnosed with breast cancer, 24 of them had some history of using one of those 3 drugs. And then we subdivided those patients into women who used them for pure prevention. They'd never had breast cancer. These are called primary. We call that primary. And the ones who used it for secondary gain, meaning that they were using these drugs as part of their treatment for breast cancer, recognizing that the drugs would also reduce the risk of developing cancer in the opposite breast. And we called that the secondary group. Okay, so there were 8 patients in the primary group and 16 in the secondary group. So the secondary group, remember, patients who already had a history of breast cancer took these drugs as part of treatment. In the secondary group, there was a median of 12 years from the first diagnosis of breast cancer to the episode that enrolled them into our study. So these patients, for the most part, were not current users. And this is a table abstracted from this data set that shows you some of the most important aspects of these women who had used the chemoprevention drug. So first of all, about more than half of them in the primary prevention group were taking the medications because they had family history of breast cancer, not a big surprise. And in the secondary group, people who already had breast cancer in their background, 56% of them also had family history. Once again, in the primary group, 5 of them also had atypical hyperplasias or LCIS in 2. This was not seen in the secondary group hardly at all. Now, interestingly enough, when these cancers developed, the majority of them were hormone-sensitive breast cancers. Now, why is that interesting? Because these hormonal drugs, the benefit has been always shown to be in reducing the risk of hormone-sensitive breast cancer. So it's fascinating to say that despite that, the majority of our patients, when they came to diagnosis, had hormone-sensitive breast cancer. It's a 50% reduction. I guess we got to remember that it doesn't mean it excludes it, just reduces it. The drugs that were used, not surprisingly, in the primary group, it was half and half between tamoxifen and raloxifene or Evista. In the secondary group, it also included someone or 2 people who were taking exemestane, which is an aromatase inhibitor. Duration of treatment, maybe they just didn't take the drugs for long enough. Well, a lot of them actually had taken these drugs for more than 5 years, or at least 5 years, and yet still went on to develop breast cancer. So what does this information tell us? Our study set told us a few things. First of all, the majority of the patients that we saw were diagnosed with very early stage breast cancer. So clearly, I think what that reflects is that women who were high risk and using prevention methods and women who already had breast cancer were committed to being surveilled and doing early detection methodologies. 5 of the 8 patients in the primary group were actually on treatment at the time of their breast cancer diagnosis. Maybe one can think about how much their risk was and how the drugs just couldn't wipe it out completely. 63% of the patients in the secondary group were users in the past and weren't even currently on medication. And the majority of the cases of cancer in the secondary group were actually occurrences in the opposite breast. And as we said, the majority of the cancers were hormone sensitive. So, conclusions? The women in our study who had used these drugs were clearly committed to doing all their screening tests in a very meticulous way, and that's why when they had their new breast cancers, they were diagnosed very early. The majority were ER/PR positive. Maybe that's a little surprising, but again, underscores the idea that using these prevention drugs, we should probably call them risk-reducing drugs because they do not completely prevent the occurrence of breast cancer. But I think, like all good research, it asks more questions than it answers. And I think that it reminds us that women who take these drugs for prevention, if they go on to get breast cancer, the hormonal treatment for the breast cancer is going to have to be modified. You don't give the same drug again. You have to go to a different drug. Also means that we need to think about what the optimal age is to start these medications. We feel like from the Atlas trial, there's a big tail of benefit to these medications. Maybe it's different in women who have breast cancer versus using it for primary prevention, but maybe when we get past that 10-year or 15-year mark, we have to think about whether or not we need to do something additional to continue to prevent cancer occurrence in these groups. So Interesting data, asks more questions than it answers. So that's the end of the talk on San Antonio for this year. I just want to add a couple more slides. We're almost done. If you're getting bored, please just put up a flare. I'll stop. But I wanted to show you some of this data because this is data that was presented last year at San Antonio that I was happy to be a part of, and there's an update that I want to give you at the end. So last year at San Antonio, we presented some data of a large trial looking at a device called the MarginProbe, which is a device that uses radiofrequency spectroscopy to look at the edges of lumpectomy specimens in the operating room. It's a device that had a lot of potential because we know that when we do lumpectomy surgery, around 20% of patients need to have a second operation to clear the margins because we don't get enough tissue to get them a clear margin around the cancer. And this device potentially could give us information in the operating room if we need to take out more tissue, and we can do it at that point and not do a second operation. This is a multi-institutional international trial. It involved 596 women who had breast cancer that was not palpable, that had been detected by some breast imaging evaluation, and all these patients were having lumpectomy surgery. After the surgeons did their typical lumpectomies according to usual standard of care, women were randomized either to just continue with the standard the way the surgeon would ordinarily do it versus adding in the use of the device to look at the tissue intraoperatively and see whether more tissue should be resected. Now, when we look at some of the results from the trial, I'm just going to show you this one slide, you can see that in people who were in the device arm, there were fewer women who needed to be recommended for re-excision procedures than women in the control arm where the device was not used. So the use of the device significantly improved the surgeon's ability to identify all areas that needed additional tissue to be removed and to accomplish that at the time of the first surgery. The use of the device didn't really change the overall volume of tissue that was removed for individual women, and fewer people were candidates for re-excision. So here's the update. At the very end of December, the device got final FDA approval. So we're really looking forward to having this available for intraoperative use in the near future. And then we're going to take further steps to see whether using the device will help us look at lumpectomy cavities or even at the additional margin tissue to see whether we've gone far enough to remove all the cancerous tissue at the time of primary lumpectomy surgery. So we at NYU were a big part of that study, and it's really, I'm really happy to tell you that the device has gotten approval and that hopefully before too long we're going to incorporate that into the standard usage in lumpectomy surgery and reduce the number of women who need to go back for re-excisions. So update from last year's San Antonio. Anyway, thank you very much for your attention. Thank you so much, and I think we can take questions.